Welcome to another episode from the Veterinary Medicine Digest. Today, we're taking a deep dive into two incredibly complex and vital components of the animal body, the vestibular system and the cerebellum. These systems are the unsung heroes behind every graceful leap, every steady gaze, and every perfectly balanced stance. Imagine a world where every movement feels like you're walking on a rocking boat, or where coordinating your limbs is a monumental task. That's a glimpse into the challenges animals face when these systems falter. Join us as we unravel their intricate anatomy, fascinating physiology, and the clinical signs that tell us something might be amiss, all while making it accessible and engaging for everyone. The vestibular system, your animal's internal gyroscope. Let's start with the vestibular system, often considered the primary sensory system for maintaining an animal's balance and its normal orientation relative to the Earth's gravitational field. It's crucial for navigating linear or rotational movements, accelerations, decelerations, or even simple tilting. Think of it as your pet's internal gyroscope, constantly informing the brain about head position and movement to ensure the eyes, neck, trunk, and limbs are all perfectly coordinated. Anatomy of the inner ear, a symphony of structures. The journey of the vestibular system begins deep within the inner ear, a remarkably complex structure that develops alongside the auditory system. Both are derived from ectoderm, but are encased in a mesodermally derived capsule. This entire assembly is housed within the petrous portion of the temporal bone, a sturdy, fluid-filled ossified structure known as the bony labyrinth. Inside this bony labyrinth, we find three continuous, fluid-filled compartments: the large vestibule, three semicircular canals, and the cochlea. The semicircular canals each have a dilation at one end called the ampulla. These bony components are filled with a fluid called perilymph, which is quite similar to cerebrospinal fluid, CSF. Nestled within the bony labyrinth is another set of fluid-filled compartments, the membranous labyrinth, which is derived from ectoderm. This membranous labyrinth consists of four communicating compartments: the saccule and utriculus within the bony vestibule, three semicircular ducts within the bony semicircular canals, and a cochlear duct within the bony cochlea. The fluid inside the membranous labyrinth is called endolymph, believed to be derived from blood vessels and reabsorbed through vessels surrounding the endolymphatic sac. The three semicircular ducts, anterior, vertical, posterior, vertical, and lateral, horizontal, are positioned at right angles to each other. This ingenious arrangement means that any rotation of the head around any plane causes endolymph to flow within one or more of these ducts, which is fundamental to sensing angular movement. Each duct connects to the utriculus, which then connects to the saccule via the endolymphatic duct and sac, and the saccule finally connects to the cochlear duct. The receptors, hair cells, and their marvelous mechanics. The magic of sensing movement happens at specialized receptor organs: the crista ampullaris and the macula. 1. Crista ampullaris. Located in a dilation called the ampulla at one end of each membranous semicircular duct, the crista is a transverse ridge formed by connective tissue. Its internal surface is lined with columnar neuroepithelial cells, comprised of two basic cell types: hair cells and supporting cells. Projecting from the luminal surface of these hair cells are 40 to 80 modified microvilli, called stereocilia, and a single modified cilium, called a kinocilium. These hairs are embedded in an overlying gelatinous structure called the cupula, which extends across the lumen of the ampulla. When the head rotates, the endolymph in the semicircular ducts flows, causing the cupula to deflect. This deflection, in turn, bends the stereocilia, especially when they move towards the kinocilium, increasing the activity of vestibular neurons that are in synaptic contact with the hair cells. This mechanism is responsible for sensing dynamic equilibrium or angular rotation. The vestibular neurons are always tonically active, and their activity is either excited or inhibited by the direction of cupula deflection. Importantly, these receptors respond to acceleration or deceleration, not constant velocity. The semicircular ducts work in synergistic pairs, e.g., left and right lateral ducts. When one is stimulated by head movement, its paired counterpart is inhibited, creating a balanced signal that the brain interprets. For example, rotating the head to the right increases activity in the right lateral duct and decreases it in the left, leading to a jerk nystagmus to the right side, which is an involuntary rhythmic oscillation of the eyes. 2. Macula. These receptors are found in the utriculus and saccule, located within the bony vestibule. Each macula is an oval-shaped plaque of columnar epithelial cells, also containing hair cells and supporting cells. Covering the neuroepithelium is a gelatinous material called the statoconium otolithic membrane, on whose surface rest calcareous crystalline bodies known as statoconia or otoliths. Similar to the cristae, macular hair cells have stereocilia and kinocilia projecting into this membrane. Movement of the statoconia, initiated by gravitational forces or linear acceleration/deceleration, bends these stereocilia, stimulating vestibular neurons. The macula in the saccule is oriented vertically, sensing changes in the sagittal plane, while the utriculus macula is oriented horizontally, sensing changes in the dorsal plane. These structures are crucial for the sensation of the static position of the head and linear acceleration or deceleration, thus functioning in static equilibrium. The utriculus macula may be more important for sensing head posture changes, while the saccule macula might be more sensitive to vibrational stimuli and loud sounds. The vestibulocochlear nerve, cranial nerve 8. The dendritic zones of the vestibular portion of cranial nerve 8 form synaptic relationships with the hair cells of both the crista ampullaris and the maculae. Their axons then travel through the internal acoustic meatus, along with the cochlear division, to form the vestibular ganglion. Upon leaving the meatus, these vestibular nerve axons course to the rostral medulla, specifically at the cerebellum medullary angle. Most terminate in the vestibular nuclei in the medulla and pons, while a few bypass the nuclei and go directly to the cerebellum, specifically the fastigial nucleus and the cortex of the flocculonodular lobe, forming the direct vestibulocerebellar tract. Vestibular nuclei, the central processing hub. On each side of the dorsal pons and medulla, adjacent to the fourth ventricle, are 4 vestibular nuclei: rostral, medial, lateral, and caudal. These nuclei form a continuous column and receive afferent input from the vestibular division of cranial nerve 8. From here, a complex network of projections extends to the spinal cord, brainstem, and cerebellum. 1. Spinal cord pathways. A. The lateral vestibulospinal tract descends ipsilaterally throughout the spinal cord, primarily from the lateral vestibular nucleus. Its axons facilitate ipsilateral alpha and gamma motor neurons to extensor muscles, while inhibiting ipsilateral flexor muscles and contralateral extensor muscles. The net effect is an ipsilateral extensor tonus. B. The medial vestibulospinal tract arises from the rostral, medial, and caudal vestibular nuclei, influencing neck muscles. C. These pathways coordinate limb, neck, and trunk position and activity with head movements. 2. Brainstem pathways. A. Axons projecting rostrally in the medial longitudinal fasciculus terminate in the motor nuclei of cranial nerve 6, abducent, 4. Trochlear, and 3. Oculomotor. This is vital for coordinated conjugate eye movements associated with head position changes, a reflex easily observed as normal jerk nystagmus, Doll's eye response. Loss of this reflex due to head injury often indicates a poor prognosis. B. Some axons project to the reticular formation, providing afferents to the vomiting center, explaining why motion sickness can cause nausea and vomiting. C. For conscious perception of balance, a pathway involves a relay through a thalamic nucleus, likely the contralateral medial geniculate nucleus, then projecting to the cerebral cortex, possibly in the temporal lobe. This function here can cause vestibular signs with prosencephalic lesions. 3. Cerebellar pathways. A. Projections from vestibular nuclei and some vestibular ganglia go to the cerebellum, specifically the cortex of the flocculus and nodulus, the flocculonodular lobe, via the caudal cerebellar peduncle. These axons also synapse in the fastigial nucleus. In essence, the vestibular system, through these intricate connections, constantly works to coordinate the position of the eyes, neck, trunk, and limbs with the head's position and movements, maintaining equilibrium during both active and passive states, and even at rest. Any interference leads to varying degrees of balance loss and abnormal head positions. Clinical signs of vestibular system disease: when balance goes awry. When the vestibular system is affected, animals often display a unique type of incoordination called vestibular ataxia, distinct from general proprioceptive or cerebellar ataxia. Neurologists categorize vestibular disorders as either peripheral lesions in the petrous temporal bone, affecting the inner ear or vestibular nerve, or central, lesions in the vestibular nuclei in the medulla/pons, or cerebellar components. Differentiating between peripheral and central often relies on identifying concurrent clinical signs from other brainstem or cerebellar systems. Peripheral disorders are generally less serious than central ones. Unilateral peripheral vestibular disease. This is a common presentation characterized by asymmetric ataxia and loss of balance, but with preserved strength. Patients with peripheral disease do not lose general proprioception and can move their limbs rapidly to avoid falling. A. Abnormal posture and ataxia. A hallmark sign is a head tilt, with the ventral ear directed toward the side of the lesion. The tilt can be subtle or severe, up to 90 degrees. B. The neck and trunk may lean, fall, or roll toward the affected side. Rolling is usually limited to the first 24 to 48 hours with peripheral disease. Persistence longer suggests central involvement. C. Patients often circle toward the affected side, typically in small diameter circles. D. Cats may adopt a crouched stance, not to be mistaken for paresis. E. Occasionally, mild hypertonia, increased muscle tone, in the limbs opposite the lesion may be observed. F. These animals know where their limbs are, so their rapid, short limb movements are attempts to regain balance. Blindfolding often worsens their ataxia, as they use vision to compensate. G. Dogs may carry their tail abnormally, making jerky movements toward the affected side. Cats may carry tails elevated. B. Nystagmus, involuntary eye oscillation. A. Normal nystagmus, physiologic nystagmus, a jerk nystagmus, slow phase one direction, fast return, that occurs normally when the head is rapidly moved. The quick phase is in the direction of head movement. B. Abnormal nystagmus. When nystagmus occurs with the head in a normal, neutral position, it's called resting or spontaneous nystagmus. If it's induced by holding the head in certain fixed positions, e.g., lateral flexion, full extension, dorsal recumbency, it's positional nystagmus. Both are abnormal. C. In peripheral vestibular disorders, the abnormal resting or positional nystagmus is usually horizontal dorsal or rotatory, with the quick phase always directed away from the side of the lesion or head tilt. The direction of the fast phase does not change with head position. While vertical nystagmus was once thought to be exclusively central, careful examination often reveals a slight rotatory component in peripheral cases, so it's no longer used as a sole differentiator. D. An eyelid movement concomitant with nystagmus may occur due to a reflex pathway from vestibular to facial nuclei. C. Post-rotatory nystagmus, elicited by rapidly rotating an animal and then suddenly stopping. The quick phase of the nystagmus will be opposite to the direction of the original rotation. In peripheral vestibular disease, this response may be depressed when rotated opposite to the side of the lesion. However, this test is often considered unreliable for determining the side of the lesion and distinguishing between peripheral and central involvement in animals. D. Caloric nystagmus involves irrigating the ear canal with cold or warm water to stimulate the vestibular receptors. While useful in humans, it's generally considered unreliable and impractical in animal patients due to the need for restraint and inconsistent responses. E. Strabismus, abnormal eye position. A. Vestibular strabismus is an inconstant, often mild ventral or ventrolateral deviation of the eye on the side of the lesion. It disappears when the head position changes, and the affected eye adducts and abducts normally, indicating cranial nerves 3 and 6 are not impaired. It's a key sign in mild disorders. B. This is distinct from a fixed or LMN strabismus, which indicates loss of innervation to extraocular muscles from cranial nerves 3 or 6. F. Postural reactions. This is a critical differentiator. Patients with peripheral vestibular disease perform hopping, hemowalking, placing, and paw/hoof replacement normally. Only the riding reflex may be altered or exaggerated toward the side of the lesion. This preserved strength and proprioception, despite severe balance loss, is paramount. G. Vomiting. While not a continuous event, an episode of vomiting at the onset of signs is reported in about 25% of cases. Bilateral peripheral vestibular system disease. When both peripheral vestibular systems are dysfunctional, e.g., bilateral otitis media interna or idiopathic disorder, there's no postural asymmetry. Balance is lost to both sides, often resulting in a crouch posture. A characteristic sign is wide head excursions. The the head swings widely from side to side, which occur almost continuously during walking and may be accompanied by staggering. Crucially, because there are no functional vestibular receptors or nerves, no normal or abnormal nystagmus can be observed. A head rebound phenomenon. Head rapidly descends ventrally beyond neutral position if support is withdrawn during neck extension. May occur, also a sign of cerebellar dysfunction. Deafness may also be recognized if the inner ear is affected bilaterally. Central vestibular system disease. Central lesions present a more complex picture, often accompanied by signs affecting other neurological systems. 1. Nystagmus. May be horizontal, rotatory, or vertical, though vertical alone is no longer definitive for central. The most reliable features indicating central involvement are nystagmus directed toward the side of the lesion / head tilt or nystagmus that changes direction with changes in head position. Resting nystagmus in central disease tends to be slower than in peripheral. 2. Postural reactions. A key differentiator is the presence of an ipsilateral postural reaction deficit or a recognizable spastic hemiparesis and ataxia due to involvement of the upper motor neuron, UMN, and general proprioceptive, GP, systems adjacent to the vestibular nuclei in the caudal brainstem. 3. Other cranial nerve dysfunction. Dysfunction of cranial nerves other than facial, 7, or vestibulocochlear. 8. Often implicates a central, pontomedullary location. Remember that facial paralysis and Horner syndrome can occur with peripheral, middle/inner ear, disease too. 4. Lesions solely affecting the vestibular nuclei on one side can cause ipsilateral signs similar to peripheral disease, head tilt, balance loss toward lesion. But isolated lesions are unusual. Paradoxical, central, vestibular system disease. This unique syndrome presents a confusing picture where the head tilt and loss of balance are directed opposite to the central lesion. This typically involves the caudal, cerebellar, peduncle, or the flocculonodular lobe of the cerebellum. A. The explanation for this paradox lies in the inhibitory nature of Purkinje neurons from the cerebellum on the vestibular nuclei. A lesion in the caudal cerebellar peduncle interferes with this inhibition, leading to excessive discharge of vestibular system neurons on the lesion side. Since the rule is that head tilt and balance loss are toward the side of least vestibular activity, the clinical signs are directed to the side opposite the lesion. B. In paradoxical central vestibular syndrome, the nystagmus is directed toward the side of the lesion. C. Crucially, postural reaction deficits will be ipsilateral to the lesion, e.g., a left cerebellar peduncle lesion causes a right head tilt, but left postural deficits. These lesions often affect UMN and GP systems. D. Paradoxical central vestibular syndrome is more commonly observed in dogs than cats. Common vestibular system diseases. A. Benign idiopathic canine peripheral vestibular disease, geriatric vestibular disease, most presumptive diagnosis for percute onset of peripheral signs in older dogs, rarely less than 5 years. Cause unknown, often thought functional, e.g., endolymph production/absorption issues. Rapid improvement, 1 to 3 weeks, residual signs. Uncommon, but recurrences can happen. No specific treatment, but diazepam or meclizine may help acute severe signs. MRI usually normal. B. Otitis media interna, a major concern, especially if accompanied by facial paralysis or Horner syndrome, which never occur with benign idiopathic disorder. Less common for percute onset than idiopathic. Requires thorough otoscopic exam and cross-sectional imaging. CT or MRI are most reliable. Can extend intracranially, potentially lethal. C. Ototoxicity. History of exposure to drugs like aminoglycoside antibiotics, e.g., streptomycin, gentamicin, which can damage vestibular or cochlear receptors. Unilateral or bilateral signs. Recovery only if caught early and drug removed. D. Hypothyroidism-induced ischemic neuropathy. Rare cause, supported by primary hypothyroidism and severe hypercholesterolemia. May relate to atherosclerosis or increased blood viscosity affecting the labyrinthine artery. E. Polycranial neuritis. Idiopathic inflammation of cranial nerves V, 7, and 8, often unilateral. Diagnosis of exclusion after other tests are normal. May be immune-mediated. F. Neoplasms. Can involve temporal bone, causing peripheral signs, or expand medially to cause central signs. Squamous cell carcinoma common in cat ears. G. Congenital peripheral vestibular system disease. Present at birth or early movement, unilateral or bilateral. affects vestibular and or cochlear nerves/receptors. Seen in German Shepherds, Doberman Pinschers, Akitas, Beagles, English Cocker Spaniels, Burmese, Siamese cats. Some improve with CNS compensation. This covers the vestibular system, a fascinating network critical for maintaining an animal's bearing in the world. Now, let's shift our focus to its close partner in motor control, the cerebellum. The cerebellum, the master coordinator of movement. Often called the great regulator of movement, the cerebellum contains more neurons than all other brain regions combined, and its rapid circuitry makes it akin to a sophisticated computer for information processing. While its role in motor activity is most clinically recognized, it also connects to sensory systems, cognition, language, and emotions. Development and anatomy. A small brain with a big job. The cerebellum develops from the dorsal part of the metencephalon. Its formation involves a rhombic lip and a superficial external germinal layer of dividing cells. These cells differentiate into crucial neurons, Purkinje neurons, forming a layer in the cerebellar cortex, and granule cell neurons, forming the granular layer. The external germinal layer persists for longer after birth in species like dogs and cats, up to 10 weeks, allowing for continued cerebellar development. In contrast, precocial species like foals and farm animals, born able to walk, have more complete cerebellar development at birth. Anatomically, the cerebellum consists of a central vermis and two lateral hemispheres. A key division is the small flocculonodular lobe, also called the archicerebellum or vestibular cerebellum, which is confined to the ventral aspect and is closely associated with vestibular function. The cerebellum attaches to the brainstem via 3 pairs of cerebellar peduncles. A. Caudal cerebellar peduncle, primarily afferent, connecting spinal cord and medulla. B. Middle cerebellar peduncle, entirely afferent, connecting pons to cerebellum. C. Rostral cerebellar peduncle, mainly efferent, connecting cerebellum to mesencephalon. Deep within the cerebellum's white matter, the cerebellar medulla, are collections of neuronal cell bodies known as cerebellar nuclei. The fastigial, interposital, and lateral dentate nuclei. The cerebellar cortex, covering the white matter in folds called folia, has 3 layers. The outer, cell-pore molecular layer, the middle single layer of large Purkinje neurons, and the deepest cell-dense granular layer. The cerebellar circuitry, facilitation and inhibition. The cerebellum receives 2 major types of afferent fibers based on their morphology. A. Mossy fibers originate widely in the brainstem and spinal cord. They synapse on cerebellar nuclei neurons and granule cell neurons in the granular layer. B. Climbing fibers originate from olivary neurons in the medulla. They synapse on cerebellar nuclei neurons and directly entwine around and synapse on Purkinje neurons. Both mossy and climbing fibers are facilitatory at their synapses. Granule cell neurons, in turn, are facilitatory to Purkinje neurons. However, the only efferent axons projecting from the cerebellar cortex are those of the Purkinje neurons, and they are inhibitory, releasing gamma-aminobutyric acid, or GABA. Most Purkinje axons terminate on neurons in the cerebellar nuclei, though some from the flocculonodular lobe project directly to the vestibular nuclei. The efferent axons leaving the cerebellum to the brainstem mostly originate from the cerebellar nuclei. This elegant arrangement means the cerebellar cortex modulates the continual facilitation of the cerebellar nuclei via Purkinje neuronal inhibition. Cerebellar connections, a web of information. The cerebellum needs extensive afferent information to regulate motor activity. A. General proprioception. Spinocerebellar and cuniocerebellar tracts bring information about limb and neck position. B. Special proprioception. Vestibulocerebellar axons from cranial nerve 8 or vestibular nuclei keep the cerebellum informed about head position and movement. C. Visual and auditory information. Tectocerebellar axons and pathways from the cerebral cortex via the pons provide sensory input. D. Upper motor neuron, UMN, systems, projections from red, pontine, and olivary nuclei and reticular formation inform the cerebellum about intended voluntary movements. The pontine nucleus is a major relay for projections from the cerebral cortex, the cerebropontocerebellar pathway, especially important for skilled motor function. For efferent pathways, the cerebellar nuclei project to various brainstem nuclei, vestibular, red, reticular, thalamus, pallidum. These connections form complex feedback circuits to the cerebral cortex, demonstrating the cerebellum's intimate relationship with the cerebrum in both motor and mental dexterity. Crucially, the cerebellum controls motor activity by influencing neuronal cell bodies in the brainstem, rather than directly influencing spinal cord lower motor neurons, LMNs. Function of the cerebellum, the regulator. The cerebellum acts as a regulator, not an initiator, of motor activity. Its primary functions include A. Coordinating and smoothing movements initiated by the UMN system. B. Maintaining equilibrium. C. Regulating muscle tone for normal body position at rest or during motion. D. Inhibiting LMNs to anti-gravity extensor muscles of the neck and thoracic limbs, rostral cerebellum. Topographically, the cerebellum can be divided into zones with specific functions. A. Archicerebellum, flocculonodular lobe concerned with vestibular system activity. B. Paleocerebellum, rostral lobe, vermis, spinal cord function, and postural tonus. C. Neocerebellum, caudal lobe, vermis, hemispheres, regulation of skilled movements. Clinical signs of cerebellar disease. Uncoordinated movements. Cerebellar disease leads to a general inadequacy of motor response and does not cause paresis, loss of strength. The hallmark is cerebellar ataxia, characterized by incoordination. A. Gait abnormalities, dysmetria. A. The most obvious sign is dysmetria, an inability to regulate the rate, range, or force of movement. This often manifests as hypermetria, an overmeasurement, where limb movements are exaggerated. B. Flexor actions, especially, appear hypermetric. C. There's a delayed onset of voluntary movement, protraction, followed by an exaggerated burst effect. The limb is raised too high with excessive joint flexion, then forcefully returned to the ground with excessive extension. D. This is distinct from the overreaching hypermetria seen with C1, C5 spinal cord lesions, where joints are extended during protraction. E. A useful diagnostic test for mild cases is the stair test, as ascending or descending stairs markedly exacerbates cerebellar signs. B. Posture. A. Patients often adopt a broad-based stance. B. Truncal ataxia, swaying of the body, also called titubation, is common. C. A fine head and neck tremor, intention tremor, is characteristic, especially augmented by voluntary movements. This is not a diffuse whole-body tremor. D. In severe cases, animals may lie in lateral recumbency, unable to right themselves, with the head and neck extended in oppositonos. E. A combination of extended neck and thoracic limbs with flexed hips is called a dyscerebellate posture. C. Muscle tone and reflexes. A. Muscle tone is usually increased spasticity. B. Spinal reflexes are normal or hyperactive. C. Postural reactions, e.g., hopping, are delayed and followed by an exaggerated response. Paw or hoof replacement may be normal. D. Other signs. A. Head rebound phenomenon may occur, similar to bilateral peripheral vestibular disease. B. Nystagmus. With diffuse cerebellar cortical disorders, abnormal positional nystagmus is only occasionally observed, with no consistency in direction and possibly changing with head position. C. Involvement of the flocculonodular lobe, or fastigial nucleus, specifically produces clinical signs of a vestibular system disorder, including loss of equilibrium, abnormal nystagmus, bizarre postures, and a broad-based staggering gait. D. Unilateral lesions typically cause ipsilateral cerebellar ataxia, spasticity, hypermetria, abnormal postural reactions. E. As discussed earlier, paradoxical central vestibular syndrome can occur with unilateral cerebellomedullary lesions, caudal cerebellar peduncle, or flocculonodular lobe, causing head tilt contralateral to the lesion, but postural deficits ipsilateral to the lesion. F. The menace response, eyelid closure to a threatening gesture, is often absent in cerebellar disease, even with normal vision and facial function. This is a crucial finding, suggesting the cerebellum plays a role in this pathway. Cerebellar diseases, a diverse landscape. Cerebellar diseases can be broadly categorized as malformations, congenital, or abiotrophies, progressive degenerations. Malformations and abiotrophies. A. Dogs. A. Congenital malformations are uncommon and often involve cerebellar hypoplasia or agenesis, e.g., absence of a vermis, sometimes with lissencephaly, potentially leading to non-progressive ataxia from birth. B. Cerebellar cortical abiotrophy is a common inherited progressive disorder. It involves premature degeneration of Purkinje neurons, often starting at a few weeks of age, but sometimes much later, e.g., Gordon Setters, Old English Sheepdogs, Scottish Terriers, American Staffordshire Terriers. Clinical signs range from mild to incapacitating. C. In Kerry Blue Terriers and Chinese Crested Dogs, a more complex inherited condition, now called canine multiple system degeneration, involves abiatrophy of Purkinje neurons and extrapyramidal nuclei, like caudate nuclei and substantia nigra. This is thought to involve issues with glutamate receptors. A DNA test is available for carriers. D. In Coton de Tullier puppies, a neonatal ataxia is a functional disorder linked to a genetic mutation in the glutamate receptor on Purkinje neurons, interfering with synaptic activity. B. Cats. A. The most common congenital cerebellar malformation in cats is cerebellar hypoplasia and atrophy caused by perinatal infection with feline panleukopenia virus, FPV. This parvovirus destroys the rapidly dividing external germinal layer, preventing granular layer formation, granuloprival hypoplasia, and can cause atrophy of differentiated neurons. Clinical signs are seen when kittens first try to walk and are non-progressive. Vaccination of queens prevents this. B. Cerebellar cortical abiatrophy is rare in cats. C. Horses. A. Cerebellar cortical abiatrophy is most common in Arabian foals and part Arabians. Onset is usually from birth to a few months, with rapid initial progression that stabilizes or progresses slowly. Affected foals show head/neck swaying and tremor, spasticity, and may rear up and fall backward. They lose their menace response. D. Ketod. A. The most common cause of congenital cerebellar signs is malformation caused by in utero infection with bovine viral diarrhea virus, BVV. Infection between 100 to 200 days of gestation leads to hypoplasia due to external germinal layer destruction and atrophy of differentiated neurons. Clinical signs are present at birth, non-progressive, and vary from severe recumbency to mild ataxia. Cerebral and ocular lesions can also occur. B. Cerebellar cortical abiatrophy occurs occasionally in cattle, often with a rapid onset between 3 to 9 months of age, progressing to inability to stand. A. Pigs. A. Postnatal cerebellar cortical abiatrophy has been reported in Yorkshire pigs, with early onset of stiffness and ataxia progressing to recumbency. Different forms exist, some with Purkinje neuronal spheroids, others with more widespread neuronal loss. Other cerebellar diseases. The cerebellum can also be affected by various other conditions. A. Inflammation. A. Commonly seen with canine distemper virus, demyelination, Toxoplasma gondii, Cryptococcus neoformans, and other fungi in dogs and cats. B. Neospora caninum has a predilection for the cerebellum in young adult dogs. C. Sarcocystis neurona can cause cerebellar disease in horses. D. Granulomatous meningoencephalitis, GME, is a non-infectious inflammatory disorder that often affects the cerebellar white matter in dogs. E. Feline infectious peritonitis, FIP, virus can cause meningitis and choroid plexitis in the caudal cranial fossa of cats, leading to cerebellar signs. F. Parasitic migration, e.g., Cuterebra spp, larvae in cats, Pareliphostrongylus tenuis in sheep/goats, Hypoderma bovis in horses, can cause cerebellar vestibular disorders. B. Neoplasia. Primary or metastatic neoplasms can involve the cerebellum, often at the cerebellum-medullary angle. Examples include medulloblastoma, glioma, ependymoma, choroid plexus papilloma, and meningioma. Cysts, epidermoid, dermoid, neuroendermal, are also space-occupying lesions in the caudal cranial fossa that can affect the cerebellum. C. Degeneration. A. Neuronal storage diseases, e.g., GM1 gangliosidosis in Portuguese water dogs, ceroid lipofuscinosis in American bulldogs and dachshunds, often involve cerebellar lesions and cause progressive neurological signs. B. Axonopathies like hereditary ataxia in Parsons/Jack Russell and smooth fox terriers and Ibizan hounds cause spinocerebellar degeneration with cerebellar vestibular signs, often with extensive spinal cord and trapezoid body lesions. C. Leukodystrophies, disorders of myelin maintenance, can also include cerebellar lesions. D. Certain plant toxicities, e.g., Swain-Sona, solanum, can induce neuronal storage diseases or diffuse CNS disorders affecting the cerebellum. E. Metronidazole toxicity can cause severe cerebellar vestibular signs, typically symmetric. F. Thiamine deficiency encephalopathy initially presents as vestibular ataxia, progressing to pupillary dilation and seizures. This condition was more common in cats fed fish diets containing thiaminase. D. Vasculaire compromise, stroke. A. Ischemic lesions or infarcts in the cerebellum are increasingly recognized in dogs, often affecting the distribution of a rostral cerebellar artery. They can cause acute onset of cerebellar vestibular signs. The prognosis is fair to excellent, as many clinical signs resolve completely. Associated conditions include hypertension, heart disease, kidney disease, hypertenocorticism, and hypothyroidism. E. Injury. Trauma to the caudal cranial fossa can lead to cerebellar dysfunction. The cerebellum can show remarkable compensation for traumatic lesions, though lesions involving the cerebellar nuclei tend to cause more severe and less complete recovery. Surgical manipulation of the cerebellum can also cause temporary dysfunction. Concluding thoughts. Understanding the vestibular system and cerebellum is paramount in veterinary neurology. From the delicate balance of endolymph flow to the intricate inhibitory control of Purkinje neurons, these systems orchestrate our animals' most fundamental movements and their perception of the world. While their complexity can be daunting, recognizing the characteristic clinical signs, from a simple head tilt to a profound cerebellar ataxia, is the first step toward accurate diagnosis and management. The differentiation between peripheral and central involvement, often subtle, hinges on a careful neurological examination and the interpretation of additional signs. Whether it's an inherited abiotrophy, a viral infection, or a vascular event, the unique responses displayed by affected animals provide crucial clues to localize the lesion and guide treatment. The ongoing research, from genetic mapping to advanced imaging techniques, continues to shed light on these fascinating conditions, offering hope for earlier diagnosis, better treatment, and ultimately, a better quality of life for our animal companions. Thank you for listening. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.